The objective of this presentation is to discuss pitavastatin and its associated myalgia rates. The prevalence of high cholesterol in adult Americans is 33.5%, or approximately 71 million people. However, only 1 in 3 adults with high LDL cholesterol has the condition under control, with less than half getting appropriate treatment. In a study carried out with 10,138 American adults, 62% of former statin users cited a high incidence of side effects as the main reason they stopped taking statins. According to the ACC/AHA Multisociety Guidelines on Statin Intensity, all dose strengths of pitavastatin have been classified as moderate intensity. Pitavastatin-mediated LDL-C reduction is comparable to that of generic statins, including atorvastatin 10 and 20 milligrams, and rosuvastatin 5 and 10 milligrams, all of which achieve LDL-C reduction between 30 to 49%. In randomized controlled trials, individual responses to statin therapy have varied. Thus, variation should be expected in clinical practice. Many patients may be unable or unwilling to continue statin therapy due to self-reported adverse effects. Over 1 in 4 people taking a statin describe some symptoms. The most commonly reported adverse effects are muscle aches and weakness, also known as statin-associated muscle symptoms, or SAMs. While SAMs are reported to be relatively low in randomized controlled trials, in clinical practice, observational data estimates these numbers may be much higher, in the range of 11 to 29%. Importantly, SAMs are a common reason for statin non-adherence. However, the mechanisms leading to SAMs remain unclear. For the highest dose of 4 mg pitavastatin, myalgia rates are only 3.1%, with less than a 4% discontinuation rate, where only 1 in 200 patients taking pitavastatin 4 mg discontinued treatment due to myalgia. In short-term controlled studies, the adverse reactions reported by patients treated with pitavastatin include back pain, constipation, diarrhea, myalgia, and pain in the extremities. Myalgia is the only side effect with a dose-dependent effect, with slight increases as the dose of pitavastatin is increased. For the 4 mg dose, the most common adverse reactions that led to discontinuation were elevated creatinine phosphokinase at 0.6% and myalgias at 0.5%.
Important safety information for zypitamag pitavastatin tablets. Indications and usage. Zypitamag is indicated as an adjunctive therapy to diet in adult patients with primary hyperlipidemia or mixed dyslipidemia to reduce elevated total cholesterol, low-density lipoprotein cholesterol or LDL-C, apolipoprotein B, triglycerides, and to increase high-density lipoprotein cholesterol or HDL-C. The effect of zypitamag on cardiovascular morbidity and mortality has not been determined. Contraindications. Zypitamag is contraindicated in patients with known hypersensitivity to product components, in patients with active liver disease, which may include unexplained persistent elevations in hepatic transaminase levels, in women who are pregnant or may become pregnant, in nursing mothers, or in co-administration with cyclosporin. Warnings and precautions. Myopathy and rhabdomyolysis. Risk factors include age 65 and greater, renal impairment, inadequately treated hypothyroidism, concomitant use of certain drugs, and higher doses of zypitamag. Zypitamag is contraindicated in patients taking cyclosporin and not recommended in patients taking gemfibrozil. The following drugs, when used concomitantly with zypitamag, may also increase the risk of myopathy and rhabdomyolysis. Lipid-modifying dosages of niacin of greater than 1 gram per day, fibrates, and colchicine. Discontinue zypitamag if markedly elevated CK levels occur or myopathy is diagnosed or suspected. Temporarily discontinue zypitamag in patients experiencing an acute or serious condition at high risk of developing renal failure secondary to rhabdomyolysis, such as sepsis, shock, severe hypovolemia, major surgery, trauma, severe metabolic, endocrine, or electrolyte disorders, or uncontrolled epilepsy. Inform patients of the risk of myopathy and rhabdomyolysis when starting or increasing zypitamag dosage. Instruct patients to promptly report any unexplained muscle pain, tenderness, or weakness, particularly if accompanied by malaise or fever. Immune-mediated necrotizing myopathy, or IMNM. There have been rare reports of IMNM, an autoimmune myopathy associated with statin use. IMNM is characterized by proximal muscle weakness and elevated serum creatine kinase, which persist despite discontinuation of statin treatment. Positive anti-HMG-CoA reductase antibody, muscle biopsy showing necrotizing myopathy, and improvement with immunosuppressive agents. Hepatic dysfunction. Increases in serum transaminases can occur. Rare post-marketing reports of fatal and non-fatal hepatic failure have occurred. Consider liver enzyme testing before initiating therapy, and as clinically indicated thereafter. If serious hepatic injury with clinical symptoms and/or hyperbilirubinemia or jaundice occurs, promptly discontinue zypitamag. Increases in hemoglobin A1C and fasting serum glucose levels. Increases of each have been reported with statins, including zypitamag. Optimize lifestyle measures, including regular exercise, maintaining a healthy body weight, and making healthy food choices. Adverse reactions. The most frequent adverse reactions with a rate of greater than 2% are myalgia, back pain, diarrhea, constipation, and pain in the extremities. This is not a complete list of all reported adverse events. For additional information, please refer to full prescribing information. You're encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.